so we don't require to achieve a steady state level in all the compartment. What is important is what is the amount of drug which has been achieved in the plasma concentration, which will determine the FXI targeting or FXI compartment. So when you stop this drug, so the elimination will take place. Meanwhile, the amount of the drug which will also decreases from V2 and V3 compartment. But what is important, we should not get confused that the amount of drug which is present in a plasma compartment is very important rather than the amount of drug which is present in V2 or V3. This will not interfere with the recovery of the patient because this will take a longer time to decrease from the V2 or V3, but the plasma concentration will decrease very rapidly. So I'll be discussing this when I discuss about the context sensitive of time. Okay. Sorry. So there is another technique which was very commonly used. That was a Bristol Profile infusion model. That's initially the manual bolus was given to fill the central compartment. 1 mg per kg was given to fill the central compartment, followed by 10 mg per kg per hour was given. That usually will fill the B2 compartment. Then 8 mg per kg per hour was given for next 10 minutes to fill the not to fill, but to equilibrate, to maintain the transfer between the V2 and V3 compartment. Then subsequent infusion was given at 6 mg per kg per hour. So this was followed very commonly before the advent of TCI pumps in 1997. But the problem with this is not all the patients are equal. Even though they have a same height, but their body composition will be vary. Suppose in the left, you can see that muscle mass is around 20 kg, even though patient is same the 52 kg weight and the same height, but fat is 16 kg. Contrarily, you can see this in the right side of the this thing. You can see there is a muscle mass is 23 kg, but fat mass is 13 kg. Even though patient has same BMI, same height, same weight, the body composition vary. So if you give a fixed rate of infusion over a period of time, the distribution between a V2 and V3 varies, and the recovery patterns also varies. So this is not suitable for regular use of Propofol maintained anesthesia. So the what is the ideal thing is a target control infusion. So if you are using a Bristol model, it's ideal to use the depth of anesthesia monitoring, where you can mildly alter the infusion. Instead of 6 mg per kg per hour, you can decrease the infusion based on the depth of anesthesia. So nowadays it has come down. The only used in the center where the TCI pumps are not available. So already I mentioned the TCI pumps or a TIVA is mainly based on the bed principle, that is bolus, where you fill the V1 compartment, then elimination, then the transfer between the V1 to V2 or V1 to V3 compartment. So you can see that this is FXI targeting. I'll be discussing about what is FXI targeting. Initially, you give, suppose you have set a FXI targeting of 3 microgram. You see there is an overshoot of a plasma concentration followed by a steady state level. Then again, you have increased the FXI target to a 6 microgram. Then there is an overshoot of a plasma concentration. Again, there will reach a equilibrium between a plasma concentration and FXI target concentration. Then when you stop the drug, both plasma concentration and the FXI concentration comes down. This is how the FXI targeting works. So this is the steady state level between the FXI and the plasma site targeting. The plasma concentration is as you know, the drug concentration which is present in a plasma. That is a V1 compartment. FX site is a site of action to produce expected clinical effects. So our site of interest is a brain. There is a CNS. So TTP is a time to peak effect. That is a time required when you give a bolus dose of a Propofol or any other drug. What is the time required to achieve a effect on the central nervous system to produce the unconsciousness or a sedation, whatever you plan? So that is called as time to peak effect. This is depends on the constant, that is Ke0. So if there is a faster the constant, then the drug will achieve a equilibrium with the effect site faster. So the one more thing very important is what is contact sensitive half time. This is a time taken from the plasma concentration of a drug to decline by a 50% after infusion of a designated to maintain a steady state. So as compared to the regular half-life, when you give an infusion for a prolonged time, so what is the time taken by a plasma concentration to decrease by a 50%? So that will called as contact sensitive half time. The drug which are suitable for a target control infusion is the drug which has a lower contact sensitive half time. If you have a lower contact sensitive half time, the plasma concentration, when you stop it, it will decline very fast and the patient recover from the anesthesia is faster. So coming to a plasma site versus FXI targeting, the plasma site targeting, plasma concentration never overshoot. So your target is what is the plasma concentration, whether it is 2 mics, whether 4 mics or 5 mics, whatever you said, that is your target. In case of FXI targeting, the plasma concentration to reach FXI target quick onset and offset. So it usually overshoots. In FXI targeting, the target is not a plasma concentration, target is a FX site, that is a brain. So there will be the plasma concentration varies or usually overshoots in case of FX site targeting. So in case of plasma targeting, at a steady state, plasma is equal to FX site. Usually after some time, based on the Ke0, the plasma concentration and FX site concentration will be at a steady state. In a FX site is based on the what is pharmacodynamic effects which are produced. How to calculate the FX site targeting? Usually it will be done either with clinically by they have done a study clinically by measuring the depth of anesthesia or time to reach unconsciousness or a sedation. Based on that, they have calculated the Ke0. So usually plasma site targeting, as there won't be a overshoot, it will be a slow onset and offset. In a plasma, in case of FX site targeting, usually plasma concentration overshoots. So to quickly achieve a target FX site target, so the onset will be faster and offset is also faster, and the hemodynamic disturbance will be much common in case of FX site targeting because there will be a plasma overshoot. Even if you set a target of 4 microgram of FX site targeting, sometimes the plasma concentration may reach up to a 12 microgram or 13 micrograms. So that's why their chances of hemodynamic perturbations will be much common in FXI targeting. Whenever you use the FXI targeting, we have to start with the lower target, then gradually increase to a higher target based on the patient response, except in case of a rapid sequence intubation. So you see here in the graph, you can see here, this left side is a plasma TCI, this right side is a FX site TCI. In the left side, you can see the plasma concentration and the target never overshoots. So green color is a FX site targeting. It takes a longer time to achieve a FX site steady state. You can see this, it takes a longer time. The amount of a Propofol administered also will be less in case of a plasma TCI. Here you can see this red line and orange lines. These are plasma concentration and plasma target, and it's a FX site target. You can see there is a plasma overshoot. There's a red color. There is a overshoot of plasma target. You can it has reached almost to 11 microgram, and the time taken to reach FX site target is much lesser. So FX site targeting, the time taken to reach a FX site will be much lesser, and patient will be it produces more faster effect, or patient will be more unconscious, or it produces a faster decrease in the depth of anesthesia when you use the FX site targeting. But amount of the drug which will be used in FX site targeting will be faster, higher. Okay, so there are various models which are available. I'll discuss with what are the target control models, infusion models which are available for a Propofol. So there are mainly 4 models, Marsh model and Snyder models, which are commonly used for adults, and Kataria and Petfuser models, which are used for pediatrics. In case of certain parameters are fixed parameters, certain parameters are variable parameters, and it depends on either weight or weight with other parameters are fixed. In case of Marsh models, all rates are constants, So all the rates are constant. That is K1 to that the distribution between the V1 to V2 compartment, V1 to V3 compartment, and elimination constant and K0. These are all fixed. This thing. Variable parameters are V1, V2, and V3. These are variable. These are varies with the weight of the patient. So V1 will increase with the weight of the patient. V2 will increase with the weight of the patient. V3 will increase with the weight of the patient. Normally in a 70 kg patient, so V1 will be approximately 15.9 if you fix a target plasma target of 4 microgram. But in case of Snyder model, so V1 is a fixed, that is 4.7 liters. The V3 and the constant between the V1 to V3 and V3 to V1 are fixed, means irrespective of the patient, V1 is 4.7 liters. So it cannot be used for a pediatric patients. So V1 is always fixed, so we can't use it for a pediatric patient. But certain variable parameters like V2 and a distribution between a constant distribution between a V1 to V2, V2 to V1, and elimination of life are a variable. These are based on the age, lean body mass, and gender of the patient. So you have to understand. So in a Marsh model, the rates are fixed. In case of Snyder model, V1 and V3 are fixed. In case of a Marsh model, V1, V2, and V3 are variable. These are based on the weight of the patient. In Snyder model, V2 and the constant between V1 to V2, V2 to V1, and the elimination constants are variable. These are based on the age, lean body mass, and the gender of the patient. Coming to a Kataria and a perfusion models, these are suitable for pediatrics. These are the commonly available models. Nowadays, Elevate model also came up even for a pediatric patients. These two models, these are almost similar to the Marsh models. These are not like a Snyder models. These are again a plasma targeting. So I forgot one more thing. The Marsh is suitable for a plasma targeting. Snyder is usually suitable for FXI targeting. In case of Kataria model, the all rates are constant except elimination of life, and variable parameters are V1 to V3 and elimination constant. These are based on the weight of the patient, because it's very important. As the weight of the patient increases in a pediatrics, the compartment size also increases. So especially the plasma compartment also increases. V2 increases and V3 also increases with the weight of the pediatric patients. In perfusion models, all rates are constant, and the variables are similar to the Kataria model. V1 to V3 are the variable. This also based on the weight of the patient. So V1 to compartment V1 to V3, this varies with the weight of the baby or pediatric patients. So nowadays, Kataria, perfusion, and Elevate models which are available for a pediatric models, Marsh model and Snyder models which are available for a adult patient. So coming to a little details about different commonly used adult models, that is a Marsh and a Snyder models. The Marsh model ignores the age. V1 to V3 increases linearly with the weight. So which is actually is not it's not based on the pharmacokinetic, because not all the patients the V1 compartment will increases or V2 compartment will increases linearly. It may be varies based on the body composition. So the Marsh is less robust patients better start with a lower concentration, because normally in a 70 kg person with when you set a target of 4 microgram, the amount of V1 compartment size will be approximately 15.9 liters. So it will deliver a higher concentration of drug when you use the Marsh model with the plasma targeting. So that's why when you less robust patients, the critically ill patients, or patients are bleeding patients, or elderly patients, or patients with the cardiac diseases where they won't tolerate the hypotension, then you have to start with the 1 microgram. Then based on the patient's tolerance, hemodynamic tolerance, then you can go on increasing. But don't rapidly increase, because it takes some time to produce a hemodynamic perturbations. So slowly increase from 1 to 2, 2 to 3, like that. If you are using a Marsh model, I don't use commonly a Marsh model in case of adults. Only a few cases I use a Marsh model. Regularly I use a FXI targeting Snyder model. So modified Marsh model is also available where K0 is 1.2 liters per minute instead of 0.26 liter per minute, which is present in a regular Marsh model. So which decreases the time required to equilibrate between the plasma targeting and FXI targeting. If the K0 is increases to 1.2 liters per minute, means amount of the drug which will be distributed to the FXI targeting will be faster. So instead, if the regular Marsh model, it is a 0.26, it takes a longer time. So the Marsh model is suitable for a plasma targeting. It is if it is a less robust patients or a patients with the critically ill or more labile patients, better to start with the lower concentration or use the Snyder model. Coming to a Snyder model, it adjusts some of the pharmacokinetic parameters for age, especially with the elimination of life. It uses the age and also the constant between the different compartments. Unlike in a Marsh model, it does not. It increases linearly. All the compartment sizes will increase linearly with the weight. But in case Snyder, it also uses the age and lean body mass. Lean body mass and age and gender is used to calculate the elimination of life. Ideally suitable for FXI targeting. If you use the plasma site targeting Snyder model, then the amount of the drug delivered to the patient will be much less, and the chance of awareness will be more because it is a V1 compartment is fixed, that is almost 4.2 liters. So amount of the drug delivered will be very less. So Snyder model plasma targeting is not suitable. Plasma site targeting may lead to inappropriately a low concentration of drug. So this is a graphical representations of various model, the Propofol model. You can see this is a Marsh model. The plasma targeting. When you identify a plasma targeting, there won't be any plasma overshoot. The target and the set target and the achieved target will be remains, and the FX site will take a longer time. You can see this. This is a Marsh model. So here the plasma targeting Snyder model, which is not used regularly because it produces inappropriately very low concentration of a drug in a plasma. So the Marsh model, you can see this is a modified Marsh model where the plasma overshoot is there. This is FXI targeting. So amount of drug which is delivered to the plasma is also very high because of plasma overshoot. Then the time taken to reach the FX site will be faster. Coming to a Snyder model, so there is a plasma overshoot. The drug delivered initially will be very high. Then the time taken to reach the FX site targeting also very fast. So Snyder is for a postgraduate level, Snyder model is suitable for FXI targeting. Marsh model is suitable for plasma targeting. The perfusion and Kataria models already discussed. Both use a weight as a key patient characteristics because plasma compartment and the V2 and V3 compartment also increases with the weight and the age of the patient. So it uses the weight as a main criteria to determine the V1, V2 and V3. The Kataria model is validated to use in a patient between the age 3 to 16 years with a minimum weight of 15 kg. The perfusion model is a variant of a Marsh kinetic model. It is between the 1 to 16 years of age and also uses the weight to calculate the elimination constant, that is K10. So nowadays, given Eleveld model has come up, it can be used from 27 post gestational age to 27 to any age, maybe 88 years of age. It can be used, and it can be used as low as 1 kg. But these are not suitable for such a low weight. Perfusion and Kataria models are not suitable for such a low weight. Minimum weight is required is 15 kg in case of a Kataria. So coming to a newer model, that is Alometric model, which is based on the pharmacokinetic as well as a pharmacodynamic calculations. So which is developed based on the Bispectral Index. So this is studied on nearly 1,033 patients. It was studied, and more than 10,000 profile samples were taken to calculate what is the exact amount of drug is required to produce a determined FX site effect in a patient. This is how the effect is calculated based on the Bispectral Index. And suppose if you are given a 4 microgram of a drug, then they will at the 4 microgram, what will be the depth of anesthesia? Then they will calculate, and it will be it was calculated in a varied group of patients, from a neonates to a elderly with a high BMI patients. So this is calculated both for anesthesia as well as a sedation. The model should be likely to be useful target control infusion in anesthesia and sedation in a population in a wide range of age and body weight, because regular models which are used nowadays, that is a Snyder or a Marsh models, which are not suitable for a body mass index which has more than 42 in case of male and 37 in case of female. But allometric model can be used for higher body mass index also. Coming to a remifentanil, which is Remington models is commonly used. We don't use because remifentanil is not available. The Remington model is applicable to a wide range of patient and characteristic. Age is used for a calculation of pharmacokinetic parameter. A gender-specific lean body mass is calculated and used to tune some of the parameters to the patient. The Minto model for a remifentanil can be used in a FXI targeting mode, but normally it is used for a plasma site targeting. But nowadays, they are based on the certain EEG parameter they use for a FXI targeting, which is not suitable. So Minto model is ideally suitable for a plasma site targeting. Dexamethasone is a more upcoming and promising drug, which is commonly used for a sedation in case of a NORA settings or a bronchoscopy. So dexamethasone was delivered through a TCI by a DAC model. So now most of the pumps, newly coming up pumps, are having a DAC models. These pharmacokinetics of dexamethasone are best described by the 3-compartment model, as I described previously. Height is the best predictor of a target setting. FX site concentrations were a model from a bispectral index, both for sedation and anesthesia. But there are a controversy whether the bispectral index can be used for the determine the effect of a dexamethasone. That is yet to be validated. So what is the disadvantage of a target control infusion? So there are multiple assumptions. K0 calculation, how to calculate the K0? That is how much time time required to equilibrate between the FX site and the plasma site. That is initially based on the clinical parameters, like how much time the patient time taken to lose the consciousness. Now the bispectral index or entropy was used to calculate this thing. But there are multiple assumptions to calculate the K0. And then the fast and slow compartment equilibrium, again, there is a fast and slow compartment. These are some assumptions that there is a constant. It is not precisely validated how much time take to equilibrate between the fast compartment and the slow compartment. And elimination of life, elimination, how much time it takes to eliminate, and what are the elimination. There are the elimination, some are depends on the different enzymes, or some are depends on the liver, some depends on the renal system. So elimination is not validated exactly. So these are made based on certain assumptions. Then there is a potential source of error. So we need to use the closed loop target control infusion, especially when we are using a neuromuscular blocking agents. The awareness during a TIVA TCI is more common when the neuromuscular blocking agents are used. So the European Society of Intravenous Anesthesia recommends that. So whenever you are using a TIVA TCI with the neuromuscular blocking agents, use any form of a depth of anesthesia. So there is a prolonged concurrent hypotension and low bispectral index associated with the increased mortality and increased hospitalization, especially after the cardiac surgery. So use the bispectral index. So never make the isoelectric. Bispectral index should not be isoelectric, because if it becomes isoelectric, especially in a patient, elderly patient, it leads to a increased chances of postoperative delirium. We have seen that if you reach for a brief period, there is a burst suppression, then there is an increased chance of delirium postoperatively. So avoid burst suppression, especially in elderly. So maintain between around 30 or 40, preferably 40 to 60 in case of anesthesia, and around 60 to 80 bispectral index score for a sedation. So don't decrease less than 30. So already I have discussed what is a time context sensitive off time. So you can see this a very important thing, this context sensitive off time for various drugs. You can see this diazepam is a very high contact sensitive off time. Even if you have brief infusion, even less than half an hour infusion, so time taken will be more than 200 minutes to decrease by half. So similarly, the fentanyl, where some of the centers they use the fentanyl infusion, we should not be using the fentanyl infusion. So it should be given either intermittent boluses, because the contact sensitive off time of fentanyl is also very high. Again, thiopentane is not suitable. Its contact sensitive off time is also very high. So if you infuse for 6 to 7 hours, it takes more than 200 minutes to decrease by 50%. So some of the drugs which are ideal for a target control infusions are dexmedetomidine, midazolam, sufentanil, alfentanil, and most importantly, the remifentanil, which decreases very rapidly because of the mode of metabolism it undergoes. And Propofol and ketamines are also very suitable for a target control infusion or a TIVA. So other drugs like thiopentane, fentanyl, and diazepam should not be used for a infusion. It can be given intermittent bolus, especially the fentanyl. It should be given intermittent doses when you are achieving a analgesia with the fentanyl. So coming to a national audit project of accidental awareness under general anesthesia. So what they have observed is, in these cases, the commonest cause of accidental awareness during general anesthesia is especially in a paralyzed patient. So because of an inappropriate low dose infusion, usually as a fixed rate infusion, more than 3/4 of 28 cases of accidental awareness during general anesthesia were considered to be preventable. So they recommend all anesthetists need to be skilled in administration of intravenous anesthesia, and these results suggest that is not currently the case. Means even in a European settings, the regular training of postgraduate, especially the administration of intravenous infusions of anesthetists was not regular. So these postgraduates and junior resident has to be trained how to administer the target control infusion, or even without a target control infusion, TIVA, how to administer the TIVA. It should be the regular practice in a postgraduate program. So which TCI pump to buy? This depends on the microprocessor with the pharmacokinetic software. Infusion pump which delivers up to a maximum rate of 1200 ml per hour. So because we need to achieve a faster induction, the visual and audible safety alarm should be present. Otherwise, their disconnections or kinking cannot be identified. It should be able to calculate infusion every 10 seconds. And make in India with the cost lesser cost nowadays available, we can be purchased. To summarize, TCI is a simple machine will do the most of the work, but we should understand the basic pharmacokinetic, how this target control infusion works. Without understanding the pharmacokinetic and the pharmacodynamic, so using the TCI pump will make the things worse. So this is based on the 3-compartment model, that is a BET principle. FXI, we should understand what is the FXI targeting, what is a plasma site targeting. We should understand what is the contact sensitive off time. We should choose the drug which are suitable, which has a lower the contact sensitive off time. So Alometric model is a feature of a target control infusion, which considers many of the parameters. Apart from age and weight, it considers other parameters also. So thank you. I think most of the things I've covered, basic part of the pharmacokinetic I covered. Thank you once again, Edward sir and online anesthesia team. Thank you very much.
Thank you, Shiva. You have wonderfully covered the complex model in a simple way to understand for the postgraduates. We will take up the questions. There are a few questions in the chat box. Most of the questions you have answered in your presentation. So once again they are asked, what is the key difference between the Marsh model and Schindler model? We can say it in one word.
The Marsh model is actually, there are the variable parameters are V1, V2, and V3. This varies with the weight, and it is based. Marsh model is suitable for a plasma targeting, and Snyder model is suitable for FXI targeting, and V1 is fixed there, where V1 is almost 4.12 or 4.2 liters. So it is suitable for FXI targeting, where plasma overshoot will be there. So that is the key difference. So Snyder should not be used for plasma targeting. It may produce the accidental awareness if you use the Snyder model for plasma targeting.
Just we are recollecting what you are told in the presentation, sir. Don't take it up. So what is the special consideration for the pediatric patients regarding the volume of the compartment distributions?
So, sir, basically, this initial age, the volume increases, especially V1, V2 increases linearly. So, we have to consider the one is when we are setting a target, what we do is we set a higher target in case of pediatric patients. So, we may not set straightforward with 6 microgram, but we set a 4 microgram. Then we see that whether the adequate depth has been reached. There is a controversy whether the BIS can be used in a pediatrics also. Then what we do is we increase the target to a higher target. Suppose 4, then we can increase to a 6. So usually what I have seen is based on the practical experience, we require higher target in case of pediatric patients because the V1 compartment is much larger per weight. So that's why we need to give a higher set the higher target.
So you said depending upon the depth of the anesthesia. So what are the monitors you use for this TCI pumps? What are the monitors?
So usually what we do, I use both the bispectral index and entropy to assess the depth of anesthesia. Not all the cases we use, but especially patients who have, suppose elderly patients, pediatric patients, or patients who are less robust, and when we are using neuromuscular blocking agents, we try to use depth of anesthesia monitors. So other fit patients where you regularly set a certain target like 4 microgram of Propofol. So you know that these patients there is not much marked deviation in the target concentration required. We don't use regularly, but what I suggest is initial days we have to use depth of anesthesia monitors so that we come to know that what patients. Some patients we have seen that 2 microgram is sufficient to maintain the BIS count of around 40. So especially patients with hypothyroidism, elderly patients, debilitated patients. Sometimes they require a 6 microgram. So initially to learn those things, we need to use the monitors, the depth of anesthesia monitor, like either BIS or entropy.
So these monitors are mandatory for using TCI. It's entropy and BIS. Anything.
Yes, yeah, especially when you use the neuromuscular blocking agents and patients with deviated pharmacokinetics, patients with the alcoholic or patients with the obese. It is ideal to use these monitors.
Okay, sir. Is there any manual regime for the infusion of the Propofol?
Yeah, I have mentioned that there is a Bristol regime is there where we can use start with the 1 mg per kg bolus dose. That is to fill the central compartment. There's a V1 compartment. Then in the first 10 minutes, we start with 10 mg per kg. That will equilibrate to a fast vessel-rich compartment. Not to equilibrate, to reach a vessel-rich compartment. Then we use for 8 mg per kg per minute for next 10 minutes. Then followed by 6 mg per kg per minute. But I have told there is a disadvantage with this Bristol model also because the variation in body composition.
So you said there is a Minto model for remifentanil.
Yes.
They are using the same concept of Propofol model, or it's a different model?
The Minto model, it is different from a Propofol model. There is a slight difference because we can't calculate the depth of anesthesia. They use the EEG for a Minto models also, but it's not suitable to calculate the analgesic parameters of this thing. But there are certain, based on the age, the concentrations are killed, even though lean body may also considered. So another what Minto model's advantage is the contact sensitive off time is very low with the remifentanil. Even if you stop at the last suture, the patient will recover faster. So Minto model, it considers it is suitable for plasma targeting. The one is. Second, nowadays they are using FXI targeting, but usage of FXI targeting with regular EEG may not be. I don't agree with it because the analgesic parameters and anesthetic parameters are entirely different.
So then the other question is, how do you fix the FXI concentration, sir? Is it the same for all patients, or it will differ for the comorbid diseases, patients with various
this requires FXI targeting. What we do is the patients with not marked variation in suppose a 40-year-old, 30-year-old fit patient, we generally start with a 4 microgram. Then we see 4 microgram of a FXI targeting. Then we see the depth of anesthesia. Suppose if the patient requests a little higher dose, then we increase to a 5 microgram, whatever the target we require. So in other patients where the patients were debilitated or patients who are bleeding patient, those patients, what we do is we set a target lower concentration from most of the times we start with 1 microgram. Then I see what is the hemodynamic perturbations, what is the depth of anesthesia, then gradually increase, then 1, then 2, then 3, like that. What is the required target to maintain the depth of anesthesia? Then we also should consider the hemodynamic perturbations, that is whether the hypertension is happening in these patients. These things has to be considered. But regularly fit patient, ASA1 patient, if you set a 4 microgram, then you can increase FXI targeting based on the depth of anesthesia. Usually they require 4 to 5 microgram of a Propofol concentration.
Thank you very much, sir. I almost answered all the questions in the chat box.
Thank you, sir.
Explanation and also your wonderful presentation. Thank you once again. Then we will.
Thank you very much, sir. Thank you for the opportunity. Thank you, sir.
Thank you. So we will move on to the second topic. So the second topic is TIVA Practical Approach, Drugs and Updates by Tushar Chokshi. He is a consultant anesthesiologist. He is a HOD of Baroda Kidney Institute and Lithotripsy Center of Baroda. He is a private practicing anesthesiologist. He has done more than 50,000 cases. He is almost interested in teaching. He is a national and state level speaker, and his infographics are famous among the postgraduates and appreciated at international level. He was an invited faculty for the NISORA for making infographics. He is the founder of TIVA and Opioid-Free Anesthesia Society in Facebook groups. He is pioneer in smartphone anesthesia practice and artificial intelligence. I don't know how he spares his time for teaching among his hectic private practice. It shows his dedication towards teaching. Welcome you to online anesthesia platform, sir. Over to you, sir.
Okay. Thank you, Dr. Edward, and very good morning to all of you. Can you see my slides?
Yes, sir.
Okay. Now I am totally a private practitioner and teaching is my passion. I started my TIVA practice since last 25 years and now I'm living with TIVA, eating with TIVA, and I want to update all anesthesiologists around the world to promote the TIVA. And you know the TIVA will be the norm in the second generation, and within 25 years the TIVA will be the leading in all anesthesia practice. So my topic today is TIVA Practical Approach, Drugs and Updates. So I want to ask you some questions to the audience. How many of you are giving TIVA and TCI TIVA? What is your definition of TIVA? What is your experience of TIVA? And will you give TIVA in your practice? Because these questions are very much necessary when you are hearing the lecture of TIVA and especially nowadays TCI TIVA, because there are so many myths and misconceptions about how to give TIVA and what will be the definition of TIVA.
Tushar, my voice is very low.
So my lecture roadmap is history, definition, types of TIVA, indications, advantages, disadvantages, TIVA drugs and TIVA combination, which drugs we are using, and which are the drugs will be combined for the starting people, those who wants to learn the TIVA practice. Methods of giving TIVA, like syringe infusion pump, target control infusion. Dr. Shivakumar has told, I have created my own infusion, that is Tushar Chokshi infusion, and closed loop systems. TIVA in different groups of patients. Which are the patients which we can give TIVA and TCI TIVA? Which surgical procedures we can do in TIVA? Which are the checklist of the TIVA? And what are the monitoring we are using? And some of the updates in TIVA. And we are using the TIVA apps, which it will be useful in your practice. And what will be the future? What is your take-home message and what is your opinion about TIVA? So if you see the history of TIVA, the people consider that this anesthesia started 175 years before, but TIVA is even older than that. In 1656, the injection of opium was given in Oxford in the dog. And since 1936, the TIVA was the changing year in our anesthesia practice, where the pentothal has changed because of the invention. And then if you see, then ketamine came in 62. This is the golden jubilee of the ketamine in 2022. Then propofol was invented. Propofol has sent second change in the TIVA practice. Then remifentanil came in 1996. Then dexmedetomidine, and newer drugs came in the ramimezolam in 2022. And in next few years, we will get a ciprofol. It's a new agent added by the Chinese company, that is in 22. It will change the practice of again TCI TIVA and TIVA. So from 1930 to 2020, TIVA is coming very much popular, and it is going even ahead than the inhalation anesthesia. So my definition of TIVA, if you see that total intravenous anesthesia, it is a technique of general anesthesia, which uses a combination of drugs given exclusively by the intravenous route without the use of inhalation agent, even gas anesthesia, including nitrous oxide. But here, oxygen, compressed air, or helium are exception. And see this word, TIVA is used in induction as well as maintenance of anesthesia. Some schools of the thought that TIVA is only for the maintenance part. It is not like that. So TIVA is becoming popular since last 2 years in Corona time, because there is a reemergence of TIVA, because gas gives rise always side effect. This is my statement. So what are the types of TIVA? TIVA is given with the endotracheal tube, without endotracheal tube, with supraglottic airway, without supraglottic airway, with nasal airway, with oral airway, or without these all airway instruments. And some of the indications, you can give TIVA in any set of the patient, from geriatric to pediatric and from OT to outside OT at any medical specialty. These are the basic TIVA indication. So almost in all surgical procedures, airway procedures, patients is having a post-operative nausea and vomiting risk, daycare surgery, even NORA situation, that is a anesthesia given outside the operation theater, anesthesia in non-operative locations, even malignant hypersusceptibility patients, remote location. The main thing is coming TCI TIVA in neurosurgery, in cardiac surgery, and even in the another type of the systems. Even patient choice is also, even I have taken my TIVA in my spine surgery, TCI TIVA in 2 years back, and I was very comfortable. Even if you transfer your patient from one environment to another environment, between one operation theatre to another operation theatre, or one operation theatre to ambulance to other way in hospitals, then also TIVA is very useful. So what are the TIVA advantages? Except for the slight prick in the arm, the patient is unaware of the having an anesthetics. The prima facie principles of giving TIVA is you must have the vein, you must take the vein. So there is no mask over the face, no sudden concentration of gas or vapor, no risk of MH, very low incidence of post-operative delirium. And in this age, the less chances of emergence phenomena. There should be no smells of volatile agent, because we are not using any inhalation agent. Reduced stress response. I know when I was practicing 20 years back without these vaporizers like Goldman vaporizer, at the end of the day, I was having a stress, and the smell were coming from my clothes when I go to home. And I was stressed. I was a little bit sleepy. But nowadays, all this thing has changed because of the newer anesthesia workstations and this TIVA TCI agents. Patient wakes up like it's from the natural sleep. Less operating room pollutions. So it's a planet well-being also with the TCI TIVA. And you mind well that in space also, there are 3 anesthesia given by my Israeli friend, Paul Zilberman, who was anesthetist. He's anesthetist, and he has given TIVA in even space anesthesia. In war situation, ambulance transfer, and unexpected condition, you do not think except TIVA. So TIVA is favorable to almost all systems like immune system, cardiovascular, even oncology, renal, gastroenterology, neuro, central nervous system. You name the system and TIVA is favorable. But the coin has 2 sides. There are some disadvantages, but I don't consider that is a main culprit of this using TIVA or TCI TIVA. First is pain on injections. Injection is irreversible. Disposable may be costly. Nowadays, disposables are not that much costly when I was looking back 10 years back. Incidence of awareness if you are not giving properly or if you are not using any monitors. Undetected error in delivery devices. Not having another apparatus to carry on the TIVA. possibility of the not finding vein. Sometimes if you are not able to find the vein, then you cannot start your TIVA practice. Shallow respiration, risk of bacterial contaminations, and difficulty in knowing blood concentration sometimes. We have learned in our anesthesia residency program that what is anesthesia circle. Here, TIVA completes the anesthesia circle with the hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, and neuromuscular blockade. You have all the liberty to have these effects. So what else you require in TCI, TIVA, or TIVA practice in your practice? Which are the drugs we are using in TIVA practice with their advantages? Almost all the drugs like benzodiazepine, narcotics, propofol, ketamine, all induction agent, dexmedetomidine, even ketomidate, muscle relaxants, and other adjuvants like diclofenac, paracetamol. I will come later in all the drug list. They are easily available in almost all operation theaters and outside operation theaters. And all these drugs can be given to any subset of the population from pediatric to geriatric with easily titrable dose. So we have ample of liberty to use TIVA drugs instead of only one inhalation. If you go long back in this inhalation agent, then after sevoflurane, there is no invention of this any inhalation agent, but this TIVA drug is a continuous process. They are inventing one by one drug every 2 years. So these are the TIVA drugs. These are the anesthesia drugs was invented in last 175 years. Almost 60 drugs, 66 drugs are invented. Out of that, we are using 45 drugs in our practice, including inhalation agent, local anesthetic agent, but we have a chance to use TIVA drugs, almost all TIVA drugs in our OT, and there are more than 25 drugs in our weapon. So what is ideal in TIVA drug? Rapid onset of action, rapid and predictable recovery, potent and lipid soluble. Even it is water soluble, and it is stable in any solution, chemically compatible with other drugs. No perivascular sloughing, not absorbed by any plastic, does not promote bacterial growth, devoid of any adverse effect, and low cost. And my most important thing is, I consider ideal TIVA drugs, it can be mixed 2 TIVA drugs or even almost 3 TIVA drugs can be mixed with each other, and we can give these drugs to any sort of the patients without any complications. So these are the TIVA tool drugs box, which I put in my OT and even outside OT. That is all benzodiazepine, propofol, ketamine, dexmedetomidine, dexamethasone, magnesium sulfate, all muscle relaxants, opioids, lidocaine, clonidine, diclofenac, and paracetamol. Almost all these drugs are available in any practice of my OT, even outside OT, and any situation when I am giving anesthesia. So which are the IV anesthetic drugs? The first drugs we are using in TIVA or TCI TIVA is propofol. It's a prime drug. I called it is a prince of TIVA kingdom in all TIVA practice and combinations. Initially, TIVA dose is 2 to 2.5 milligram per kilogram if you are using as a bolus dose with induction. In any mixtures of TIVA, like if you are combining with ketamine or if you are combining with any narcotics, then you give 1 milligram per kilogram. This is all this without TCI. And in infusion, usually we give 6 milligram per kilogram. And in all over the world, TCI TIVA practice, propofol and ramifentanil is the most ideally used this combination in all over the world. And on right side, there is a TIVA dose and TCI dose with the sedation, light pain, laryngeal mask, moderate pain, surgical anesthesia, intubation, strong pain, and deep anesthesia. So first thing in that, when you are practicing TCI TIVA, then your primary drug is only propofol. Without propofol, TCI TIVA is not exist. I have created, Dr. Edward has said that I have created all the infographics. So this is the propofol infographics. I will share with him and you will get it afterwards. Ketamine. Ketamine is the most popular drug among all anesthesiologists across the globe since last 50 years. There is one survey done just 5 years back with all the anesthetists across the globe, which is the most popular drug in the anesthesia armament. I'm telling most popular. Then ketamine was the 49%. I called it is a brahmastra for the anesthesiologist in TIVA. When TCI TIVA was not there, just 2-3 years back in my practice, then I was using, even today also I'm using ketamine in my practice as a sole combination with TIVA mixtures. It's a key role and main drug in TIVA. It's a base analgesic, amnesic, and opioid sparing effect. It's an NMDA antagonist. Dose is less than 0.5 milligram, but you can give as a sole anesthetic agent with some of the propofol or ketamine up to 1 to 1.5 milligram. It has got an anti-hyperalgesic and anti-tolerance effect also, and it is a very good indication even at the withdrawal of the narcotics when you are giving ketamine. Ketamine TIVA, it produces rapid hypnosis and profound analgesia. It can be mixed with all types of anesthetic and narcotic in a single syringe. So this is the beauty of ketamine. So it can be mixed by midazolam, it can be mixed with the propofol, it can be mixed with the dexmedetomidine, and it can be mixed with the another 2-3 drugs in the pipeline like ciprofol and ramimezalam. It is a very much established drugs for the TIVA. This is ketamine infographics. One of the most used drugs in nowadays is dexmedetomidine. I call dexmedetomidine as the most ideal anesthetic agent nowadays. Dexmedetomidine has got an analgesic and anesthetic effect, hypnotic, sedative, and it is 7 to 10 times more potent than the clonidine. It is a most ideal anesthetic agent. It has got even opioid sparing effect. And you know, in pediatric TIVA, without TCI, Dexameth combination is becoming very popular in pediatric TIVA or opioid-free anesthesia. And you find in PubMed more than thousands of articles about this Dexameth since last 2 years. Here the patient is sedated but arousable. So it is, I called it is a conscious sedation or physiological sedation. Now how this physiological sedation is working under the dexmedetomidine, I will give one of the examples. When you are sleeping in the midnight and you have an urge of going to washroom, you go to the washroom and come back to your bed and you again sleeping. So that is the way the dexmedetomidine also give rise to sleep. It is called a conscious sedation or arousable sedation or physiological sedation. This drug is becoming widely popular in all over the world in all anesthesia practice. The dose is given 0.5 to 1 microgram and maintenance infusion is 0.6 to 0.7 microgram per kilogram per hour. And I told you that in pediatric TIVA, Dex is with ketamine is combination is mostly preferred. And I used to give even in my ENT practice, urology practice, or even gastro practice with initially I was using Ketofol, that is a ketamine propofol, but now I have switched over since last 2 years to Dexameth. This is dexmedetomidine infographics. Now I am promoting since last 3 years dexmedetomidine in use of all the private practitioners in my area, and I have created this prayer for all people. What dexmedetomidine says: hey buddies, I am dexmedetomidine. My pet name is Dax. I am your complete friend to play with you in all games: IV, IM, oral, spinal, and nasal. But my favorite game is intravenous with all stages: sedation, hypnosis, analgesia, and anesthesia. I love to play with the small babies, to old age players. So this dexmedetomidine can be given to all age groups. But during playing with me, be careful. I am very delicate. Fall down with the weak players because it causes hypotension as well as bradycardia. I can also play in indoor stadium. It can be given in ICU patients continuously for 48 hours, not more than that. I am always available to play with you and allowed me to play with others. Let us play, enjoy with me, and don't neglect me. So I will recommend all the listeners in YouTube and this forum to use dexmedetomidine in your practice frequently. One of the drugs which I am using very occasionally in my cardiac patient, that is etomidate. It's a very cardiostable drug. Used mainly in hemodynamically compromised patients, and it is given in sedation, TIVA, ICU, and in geriatric patient in the dose range from 0.1 to 0.3 milligram per kilogram body weight. This is etomidate, this infographics. Recently, since last 6 months, I have started with etomidate plus ketamine combinations for at least 10 patients, and I am very happy. Some of the opiates we are using in TIVA practice, that is fentanyl and remifentanil. I'm not using fentanyl in my practice, but remifentanil is not available. Nowadays, my practice is of TIVA practice, that is opioid-free total intravenous anesthesia practice because of my since last 2 years of corona practice. Fentanyl is given is a 3 milligram per kilogram over 30 seconds, followed by 2 microgram, then 1.5 microgram, then 1 milligram per kilogram, which was I was practice. Now remifentanil is, Dr. Siv told that it is not available in India, but we are fortunate within 6 months, 2 companies are coming in India with the remifentanil. It is available as a 1 milligram per vial, 2 milligram per vial, and 5 milligram per vial. Initial dose is 1 microgram per. It's a very short acting drug and a very beautiful drug. You see all over outside India, all the countries, more than 190 countries are using this remifentanil in all the anesthetics. But India, we don't have this molecules, so we are not able to use. But in TCI TIVA, remifentanil propofol is the leading in this practice. This is fentanyl infographics. This is remifentanil infographics. And the new agent I told you in 2020 by Japan, this ramimezolam came in pipeline. And this is the third situation in 775 years in TIVA. That first in 1936, where the pentothal was introduced, in 1977, when the propofol was introduced, and in 2020, when the ramimezolam introduced in this world, it has changed the anesthesia practice. It is also called as a switch on, switch off anesthesia with ramimezolam. And it has got a benzodiazepine and opioid property together. It will be available. I don't know when it will be available. Otherwise, rest of the countries in all over outside India, like Japan, USA, China, and European countries, it is available. But mind well, it is when it will be available, will be 1800 rupees for 1 ampule. So very much costly. Some of the adjuvant TIVA drugs I am using, that is midazolam, 0.05 milligram per kilogram. Now I have stopped using these drugs. But the thing you should remember that total dose should not be more than 10 milligrams. Midazolam infographics. One of the versatile drugs, old wine in a new bottle, that is magnesium sulfate. It's a main agent giving TIVA, or even in any practice, like if you are giving spinal anesthesia, even any sort of anesthesia, I will recommend to use magnesium sulfate. It's an analgesic adjuvant useful in patients with recent total intravenous. It reduces propofol, dex, and atracurium, and it improves the quality of postoperative analgesia. It is available as a 2 ml ampule with 500 milligram per ml, and its cost is not more than 10 rupees. I called it as an intravenous oxygen because of the, it has got a 32 effects in the anesthesia practice, mainly with the antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizures, anti-shivering, anesthetic adjuvant, antacid, and mild sedative. I called it as a, oh my God, oxygen with magnesium sulfate is a very good combinations in our practice. I told you about the 32 clinical effects of the MgSO4, and this is magnesium sulfate infographics. Second drugs in adjuvant is my very favorite drug is dexamethasone. I think almost all anesthesiologists across the globe, they are giving dexamethasone. At least in Indian subcontinent, I heard that everybody is giving dexamethasone in their practice. It is widely used in TIVA as an adjuvant. It has got anti-inflammatory, treats the postoperative nausea and vomiting. It suppresses the inflammation. It has got a good analgesic effect. And when your patient wakes up from the anesthesia, then there is a sense of well-being, good quality of recovery. And single prophylactic dose of dexamethasone, at least 6 to 8 milligram, can be given to irrespective of sex, age, and disease. And even I am giving to even diabetic patients. There is one study was done when you give a diabetic patient this one shot of this dexamethasone of 6 to 8 milligram, then it will not increase the blood sugar more than 15 to 25 milligram in a once taste. So it's a very good friend for the anesthesiologist. It has got antiemetic, antinauseatic, anti-inflammatory, analgesic effect. I will recommend to all the anesthesiologists who wants to start their TIVA practice, just give dexamethasone, even if you are giving local blocks or TIVA, or even in your monitored anesthesia care, you just give 1 dose of this agent. This is dexamethasone infographics. Third drug, my favorite drug, is best companion for the anesthesiologist, lidocaine. Without any blinking of eyes, you give this lidocaine. It has got an analgesic, anti-hyperalgesic, anti-inflammatory, reduce the opioid analgesic consumption, anti-arrhythmic, improves the patient's outcome, and decrease the aerosol and droplet during the extubation. I combine this agent, even my intubation and my extubation times. This is intravenous lidocaine. It's a very magic drug. Why I called it is a magic drug? Suppose in your body, like there is a machine is there, even some car engine is there, and if your car engine is disturbed and something is done, then it will be having a very good effect. Like if the body systems are disturbed in suppose cardiac, then lung, everything will be disturbed. Then if you give intravenous lidocaine in your anesthesia practice, then it causes a magic. All the systems will be regularized in all their functions. Some of the other analgesic agents I am giving is paracetamol and diclofenac sodium. Paracetamol frequently I am giving to all my patients in the dose of 1 gram infusion. It's a preemptive analgesic. It has got a opioid sparing effect. Loading dose is 30 milligram per kilogram and very excellent adjuvant in pediatric TIVA and TCI. Diclofenac sodium. It is also a very good agent, but be careful in the renal, hepatic, pulmonary, and heart failure patients. The thumb rule is that if you are using these two drugs in your TIVA practice, then always give before the surgical incision and to inhibit the prostaglandin receptors. Once the surgeon has put the incision and then at the end of the surgery or middle of the surgery, if you give this paracetamol or diclofenac sodium, the effect is only 50%. So my request is whenever you are using these two agents, then always give before the surgical incision. This is paracetamol infographics. This is diclofenac sodium infographics. Now, esmolol is one of the good weapon in my TIVA practice. It has got a opioid sparing, gives central analgesia, and I called it as an emergency friend of anesthesiologists. Because why? I do a lot of laparoscopic anesthesia, and in that, without anything, I start esmolol infusion in my all patients. Because the beauty of this agent is again, it can be given with even more than 2 years, up to pediatric age, up to 2 years of age, because it is gives central analgesia. And the main beauty is why I like this agent is simultaneously it causes bradycardia as well as means it lowers the heart rate as well as it gives hypotension. So I use this and I recommend that instead of other beta blockers, you start using esmolol. This is esmolol infographics. Now, I am a man of combinations. So I usually combine my all TIVA drugs. So what to understand before mixing any drugs for anesthesia? We have learned the anesthesia triangle or anesthesia prism. Then there are three components: hypnosis, analgesia, and relaxation. And any medications, any anesthesia drugs, any adjunct drugs enters this prism, they are going under the process of pharmaceutical pharmacokinetics, pharmacodynamics, and thermodynamics with mixing with each other. If you learn these principles, then you will conquer the combination of anesthesia drugs mixtures. So the rule is not mix more than 3 drugs at a time. And this is a beautiful article given in Coleman Journal of Anesthesia, where they have studied a combination of all the drugs with each other. Like Propofol. Propofol can be mixed with each other. It can be compatible. Green is compatible. Yellow is not compatible. Yellow is non-conclusive, red is not compatible, and white is not tested. If I give the Propofol and Ketamine, then Propofol can be compatible with all the drugs except the muscle relaxant. Ketamine can be mixed with any drugs you name it in your practice. I have created one of the TIVA kingdom. Those who wants to start their TIVA practice, here we are the king. Either we are king or queen. Our prince is Propofol. And the supreme commanders are Ketamine and Dex. Our commanders are fentanyl and remifentanil, and others are our soldiers. So whenever you want to start your TIVA practice, here king will decide with their military battle and TIVA to whom the sends alone or in combination. So in TIVA or TCI TIVA, prince is the first warrior to go in the battle of the TIVA practice. In TIVA maintenance, prince with the other two supreme commander or other commanders are the base military king. If you are not using TCI machines, then Propofol with Ketamine or Propofol with Dex or Propofol with fentanyl or Propofol with remifentanil are the primary combinations we are giving. In pediatric TIVA, you know, I have started a Dexameth combination instead of Propofol. So in the absence of presence of prince, when you are not using Propofol, then two supreme commanders go to the win some battles. So remember, in pediatric TIVA, now people have started a Dexameth. These are the combination I am using, and it is universally accepted in all over India. That is, first is KPD mixer. This KPD mixers I started 10 years back with a combination of Ketamine, Propofol, Dexamethasone. Ketofol, Ketodex, Dexameth, or fentanyl propofol, remifentanil propofol. And in South India, one of my friend is using in exclusively at one of the Kerala hospital, propofol, dexamethasone, fentanyl, midazolam, dexamethasone, fentanyl, and Ketomed. So these three combination, Ketofol, Ketodex, Ketomed, is established combinations. You have to remember only that it can be combined in the dose of 1-1-1, either 1 milligram propofol, 1 milligram ketamine, or 1 microgram dexamethasone combinations. And this is KPD-TIVA. I have developed these mixtures just in my practice when there was no TCI machines available in India. And in my gastro practice, I was doing at least 10 procedures in a day. So I developed this KPD mixtures. It's a mixture of ketamine, propofol, dex. It is a mixture with the 1 milligram and 1 microgram. Combination of all these drugs permits lower dose of each individual drugs. I use it as a bolus maintenance in short cases, and it gives excellent analgesia and anesthesia. To tell you, I have completed more than 10,000 patients with this combination. Touch wood, there was no any major problem. It decreases the dose of individual, stable hemodynamics, it decreases the airway complication, and it gives a rapid recovery. Propofol fentanyl combination we were using frequently in our older days. Here the only propofol dose reduction by 50% with this remifentanil. Now this RPTIVA, remifentanil propofol combinations. Here the propofol dose is reduced to half, and reduction is 50%. And most widely used TIVA combination, as Dr. Shivakumar has told in his practice, in TCI. Now, how to give TIVA in your practice without TCI? TCI is one of the methods to give TIVA, but which are the other methods? Either with a single drug or with a combination of drug, either with a single syringe or mixture of the drugs, or with only one drug. You have a single different syringe with the different drugs. Either you give the continuous IV infusion through the drips or with syringe infusion pumps. This TCI machines or TCI pumps, and one of the established method is closed loop systems, automated drug delivery through this. Here also we can give. It was developed in India by Dr. J.D. Puri. So this is one of the favorite, and my favorite is also single syringe TIVA. No additional systems are required. TCI or closed loop system, single syringe. I am combining 2 or 3 drugs in my practice, or I put one drug for one syringe for one drug, or another syringe for another drug. Only one syringe or syringe is used for the advantage of dose titration and a single level. Here, the beauty of this is that you can practice in any medical specialty. Suppose you do not have hi-fi machines, or you do not have any extra monitors. At that time, you can practice in NORA situations, like in gastroscopy unit, in cardiac catheterizations, or in MRI suits or radiological procedures. We can have this liberty to use single syringe TIVA. Manually controlled infusion, manual dosing of anesthetic drug with fixed infusion dose rate, with syringe or with IV drips. Here I will tell you that there are some apps are available to control the infusion rate. So I will come later in my this lecture. Dr. Shivakumar has told about the Bristol regimen. I will not go in detail. Now people are asking me, when there was TCI machine was not available in India, now this is available. But can we dilute propofol in any solutions? Answer is yes. The rule is you can dilute propofol in 5% glucose, 0.9% NaCl, ring electrode, or DNS. The rule is that 1 part of the propofol and 4 part of the dilution. So when TCI machine was not available, at that time I was preparing propofol infusion. So my method was, I was taking 100 ml of normal saline, removing 20 ml of solution from that infusion, and adding 1 bulb of 20 ml propofol 1%. So it comes around 100 ml. So it causes, it causes 2 milligram per ml propofol, and maintenance dose was around 6 milligram per kilogram. And I was not using at that time BIS machine also. So in 65 kg weight of patients, the 30 minutes this infusion was, and I was preparing for 1, 2, 3, whatever the infusions are there. In the maximum 6 hours, I had given these infusions. And this is from the American websites, those who have established this method. Total intravenous anesthesia sets are available in the world. Now, target control infusion. Dr. Shivakumar has told you very nicely in details. It's a infusion controlled to achieve preset drug concentration in plasma or effect site. Two type specific drug model, what he said about the Snyder or this Minto or Qatari or Perfusor, and another LEVEL model, that is general purpose model with all the drug softwares are available nowadays. And these are the models available in India: Acromed, LEVEL, SP Medcaptain, BD, LRS, PKPD, and B Brown. Even China people came with a single syringe TCI, double syringe TCI, and 3 syringe TCI. And he is the person who has invented these TCI machines, deprefuser in their practice of TIVA, Propofol TIVA, first time in the world, 1996. So main benefit of TCI TIVA is more predictable onset and more predictable offset. Now, what Dr. Shivakumar has told about this TCI TIVA machine in an LEVEL model, the machine will itself says that when the patient will come out after extubation in how many times, suppose in 2 minutes, 3 minutes, or 4 minutes. That is the beauty of TCI TIVA in your practice. Even in Glasgow, patient control sedation by TCI, like patient control analgesia. So patient control sedation by TCI is also developed by these people recently in 2022. And these are the models are available. And this is a general purpose model. One TCI pump for all the drugs with different drug software. I had developed without TCI machine my infusion, that what I was following since last 10 years. KPD infusion, ketamine, propofol, dexmedetomidine infusion, and propofol infusion in the range of this what you can see. Now, closed loop anesthesia delivery system, automated total intravenous anesthesia. Here the input is drug delivery like propofol and opioids, and output is another anesthesia depth monitors like evoke potential, bispectral index, narcotrain, or entropy. Why it is called a closed loop system? Because there is a input is drug delivery and output is monitor. Here, whatever the vital monitors will be noted in the computer, and according to computer's command, the drugs will be delivered in the body, and the vicious cycle like goes in like that. And this is the closed loop anesthesia models available in the world. Even people have introduced the eye control RP, that is ramifentanil, propofol, robotic control of the TIVA and clades. It is US FDA approved. This is the new things which you want to know. You want to know that part. It was developed in Vancouver. And this is a pediatric anesthesiologist had developed. And even they are coming with the eye control RPR, that is with relaxant also. Now, some of the sets of the patient like pediatric, geriatric, and obese patients, I am giving all this TIVA in my practice. In pediatric TIVA, you must consider that you start at least TCI TIVA. But pediatric TIVA is viable project. And here I told you about Dexameth. That Dexameth is coming in a way, all pediatric induction like ENT procedures, urology procedure, where short GA, I am giving Dexameth, and my patients are within 2-3 hours at daycare procedures. But avoid TIVA in neonates. TIVA in geriatric patients. Compared with inhalation agent, TIVA is more suitable as it is less observed effect on cognitive function in all elderly patients after surgery. My golden statement for using TIVA, TCI or TIVA in your geriatric patient is go low, go slow, and always follow if you are not using TCI machines. Because you give very low dose of the drug, you give very slowly, and always follow this regimen. The rule is multi-para monitor and oxygen is must during when you are giving TIVA. I get so many patients for at least 2-3 minutes of anesthesia, 5 minutes of anesthesia for geriatric patients, like shoulder manipulations for cystoscopies. And so at that time, I'm giving very slowly, very low. And so TIVA practicing my geriatric patients are, I'm very happy with monitoring and oxygen. TIVA in obese patient. TIVA is an excellent method for the administering general anesthesia to obese patient also. And my thing is that here I am always using scoline when I am intubating for this obese TIVA. No relaxant technique is not advisable. So suxamethrin for intubation is ideal choice in TIVA. Here also multi-para monitoring and oxygen is must. Even ASA3 patients is also, I can give any ASA3 patient this TCI or TIVA practice. TIVA can be given to seriously ill patients. Multi-para monitoring and oxygen is must. And choose the most appropriate TIVA drugs, like even sometimes you can use etomidate in these patients, whether the patient is elderly or young, whether the patient is obese or non-obese. So surgical procedures done under TIVA, from OT to outside OT, from pediatric to geriatric, from any surgical to medical specialty. So what else you require in your TIVA practice? Start your TIVA practice. Some of the TIVA checklist: all anesthesia drugs, airway equipments, oxygen, multi-para monitors are must before giving TIVA. And ensure no leakage from cannula, and patient's IV cannula is always visible during surgery if possible. It was very much, I have seen in Corona time also that when I was giving TIVA, see, there was a reemergence of TIVA. One of my article came in Indian Journal of Anesthesia when I started giving TIVA in Corona patients, and it has become a very popular. So I was blessed with this TIVA practice in that time. Syringe should be labeled with drug name, date, and concentration. I am very particular about the labeling of these all my TIVA drugs. Infusion line should be checked every 15 minutes. The infusion set through which TIVA is delivered should have a lure lock connector. It is just not like that you just put in IV sets and went on one end to each end, but you have to screw it. If BC is used, check placement before and after surgical draping, and at the end, ensure all tubing IV cannula which had TIVA drugs by any method. Flush to prevent the inadvertent bolus in the ward. Some of the TIVA monitors which I want to take. See, I am an old generation anesthetist. My practice is 32 years. I consider myself as a best monitor as an anesthesiologist. So whatever the monitors comes in my practice, but still I am the best monitor as myself. So for TIVA practice, you must your ear and your eyes should be open. You should see when you are giving TIVA, loss of response for shaking and shouting, loss of hemodynamic response, absence of tachycardia. And when you are using machines, then must use multi-para monitor, bispectral index, evoke potentials, and process ECG monitor, even narcotrend, even entropy. And people have started another monitors like NOL monitors and QCon, QNOX. All monitors are coming as a anesthesia depth monitor. So TIVA has become more popular and practical and possible due to two main reasons. First is the advanced knowledge of pharmacokinetics and pharmacodynamics properties of the drugs such as Propofol, Ketamine, Dexameth, and newer short-acting opiates, making them suitable for intravenous administration. Here I want to tell you, when TCI machine was not there, then at that time, TIVA was practiced by all the drugs. But now the TIVA is with Propofol. The only drug where available was Propofol and little bit Remington. Since last 2 years, means Dexameth, Ketamine, even this another narcotics, and even they started with midazolam and everything. TCI machines are available for these drugs also. So second, new concepts in pharmacokinetics modeling coupled with the advance in the technology of infusion pumps, which allows the use of algorithms such as syringe infusion pumps, target control infusion, and closed loop system. The first generation TCI machines are now over. Now second and third generation TCI machines are developed. And still the Propofol with Remington is rolling all over the world. Some of the TIVA apps I want to tell you. iTIVA. This is do TIVA with your smartphone in volumetric pumps in a pharmacokinetic manner. Then IV calculator infusion when you are not using your TIVA, TCI, TIVA machines. Then infusion calculator, anesthesia software. And this is the only textbooks are available in the anesthesia armamentarium by Epsilon, that is target control infusion. And these books are available with me in software copy. I will give it to Dr. Edward and you will get it from him. So my down statement is TIVA is in fact patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly, productivity friendly. So this is how it is used, and TIVA will be a norm in future practice. In future, auto TIVA through artificial intelligence and metaverse with the help of TCI and BIS are available. That is a very wide topic. When I have seen with my friends from Israel that how he has given TCI TIVA in space. Dexameth as TCI model by Hollywood and Dick launched in 2020. My dream is that like vaporizers, syringe pumps and TCI systems should be integrated in anesthesia workstation. TIVA will be a norm in new normal, and TIVA will rule in all anesthesia practice by techniques by 2030. Now people will came in the like jackknife, Swiss jackknife, all in one TCI and closed loop anesthesia, two machines simultaneously. And even if you are tired and if you want to play with your TCI pump, then there is a screen available on and they have developed the screens, and you can play any game with this your TCI machines also, TCI pump only with your pump. This your jack. This today I am facing this type of my complex theater with wires, gadgets and monitors and everything. I'm fed up with this type of practice. So my dream is that I should come with the future anesthesia workstation. I should have only one cabinet where there is only one button, starting with all different alarms and everything. Whenever I want my patient to put on a sleep mode, then I will start that button. And when I want to awake that patient, I will put that button on the awake mode. And all the monitors, vaporizers, drugs tank, then everything will be oxygen, then everything will be available on this cabinet only. And over and above, whenever you're tired and if you want to have your coffee, then you can have a vending machine also in that. It can be movable to elder. This is my dream, but it will be switch on, switch off anesthesia machine in 2030. And you believe we will be witness of this type of the machines. Newer drugs are coming in. Remington already came. Sugammadex also came. Now, Heptiva, Duzitol and Propofol, they are coming in market within 2 years. So my take-home message, think outside the box, step in your comfort zone with TCI, TIVA and TIVA with safe anesthesia, safe surgery, safe patient, safe environment, and safe yourself. So total intravenous anesthesia with TCI are safe alternative to the inhalation anesthesia with lots of advantage over the later. TCI pumps and advanced monitor make administration of TIVA easy and precise. Manual control infusion using regular syringe pump can be used to deliver pre-calculated doses. And new intravenous hypnotics and analgesic agents with favorable pharmacokinetic properties have made TIVA more popular in wide era of varying clinical scenario and anesthesia demands. So don't think that when I will start my TIVA practice or TCI TIVA practice, just start today onwards. My request is at least in your practice, at least for 20% of the patient, you start with TCI TIVA and TIVA. So which steps you will reach today's after this session, you will tell me, I won't use TIVA, I can't use TIVA, I want to use TIVA, how do I use TIVA, I will try to use TIVA, I can use TIVA, I will use TIVA, yes, I have used TIVA and TCI TIVA. I want your first steps, that is, I will use and I have used TCI TIVA. I have created a Facebook TIVA group, just join it. There are different societies are available in the world. You can be a member of this society like EuroSiva, World Siva and siva.aca.uk. And within 2 to 3 months, we are also forming ISIVA, that is Indian Society of Intravenous Anesthesia, with all the TCI lovers in the India. So always I love my TIVA and TCI TIVA. Thank you.
Thank you, Tushar. Wonderful presentation, and your presentation is loaded with so much of tips for the young generation of postgraduates and also the practicing technologists. There are many appreciation in the chat box also. Awesome presentation and a wonderful future dream. Like that, there is many comment in the chat box also for your wonderful presentation.
Thank you,
we
sir.
will take the questions in the chat box. Sir, can we use the TIVA in the MRI rooms? Do we have any MRI compatible TCI pumps?
Yes, MRI TCI compatible pumps are available. How they are using? Suppose they have a pump, same pump will be used, but they have a cabinet which is compatible with the MRI machines, and they will put that TCI pump in that cabinet, which is MRI compatible. That I had seen in this Ganga conference. I think Dr. Siva has also seen this, and we can use TCI pumps in the MRI suits, but you should have that outer box which are compatible with the MRI machines.
Okay, sir. Have you used TIVA in dental and Aphthal practices.
Oh yes, that is called a monitor anesthesia care. That's what I want to tell you, that TIVA can be practiced in any situation. I am giving TIVA even in my skin clinics also. My skin friends, skin specialists, they are calling me at least 3 to 4 anesthesia per month in their office procedures. At that time, I do not have hi-fi anesthesia working station. So I require only oxygen and suction machines and some of the basic emergency bag like resuscitator and some of the drugs. At that time, TIVA is my friend where I can give for daycare procedure. So ophthalmic, dental, or skin clinic, or taking some biopsy at an office procedure. Even I started with the plastic cosmetic surgery with the TIVA TCI and TIVA. So TIVA can be practiced outside OT, inside OT, transfer of the patient. So that is called that it's a beauty of TIVA.
So you're using everywhere the TIVA.
Yeah, TIVA can be used with everywhere. You tell me I can give TIVA in any part of the world, any space, any building, any. I will require a little bit except anesthesia machines. I don't want to have vaporizers. Even without TCI also TIVA is viable. So see, Edward, what is the beauty of TIVA? We have ample of drugs. For pediatric, we can give these drugs. For geriatrics, we can give these drugs. With one syringe, with 2-3 drugs, and for 1 minute to even 1 hour anesthesia. You see this radiological suits. I am having a very good practice in gastroenterology unit where I have almost 10 procedures in a day. So there TIVA. So why I have inclined in TIVA since last 2012, that was the reason. In my gastroenterology friend, he was not having anesthesia machine, even I am telling you, 20 years back. So I have to use some of the drugs which are favorable for me. So I have inclined to TIVA practice in 1998. And from that day onwards, I am loving TIVA. And still now I have anesthesia workstation also for ERCP patient. I'm intubating with gastro LMA also, but that is a newer thing. But the TIVA, that is the inspiration for TIVA in my practice.
Sir, you are saying that you can use TIVA everywhere.
Everywhere.
TCI, they say the mandatory monitor is Wisp monitor and Here, what monitors you will use, sir?
See, that also I have discussed with one of the giants in, I will not keep the name, TCI TIVA person in the Switzerland also, where he specifically told that when you are using TCI TIVA, at that time, BIS monitor is compulsory. But when you are using TIVA only, that is total intravenous anesthesia without TCI, my 95% of the practice is with TIVA only. Hardly I am using 5% of my practice with TCI TIVA, where I am using BIS monitor, no doubt it. But when I am combining with my drug with dexamethasone, propofol or ketamine, there are hardly chances of going patients under awareness or something like that. You see all the pharmacological characteristics of all these drugs. Even my colonoscopy patients, when I am giving anesthesia and when they wake up and when I ask them, okay, how was the experience? At that time, fantastic. Even I had gone with the TIVA anesthesia with my spine surgery and I was comfortable. I was not having any memory. So awareness is not a big problem and awareness is not there when you are combine. So that is the beauty of TIVA. You can combine the drugs with any concentration with single syringe, 1 drugs, 2 drugs, or even you can give 1 drug, you can give 2 drugs and you can combine 3 drugs also. That is my practice and it was established. See, the fundamental rule of this combination of drugs, whenever you combine any drugs in your practice, like propofol, ketamine, propofol, dexamethasone, or whatever, you have to use these drugs mixture within 6 hours. Because after 6 hours, there is a crackling, there is a gas formations, or there is a different pharmacokinetics and dynamics property disintegrations with this combination. So whenever there is a beautiful article is in PubMed when they have come in all these drug in combinations. So you cannot use these drug mixtures like you mix propofol and ketamine and you will use after 12 hours. Not like that. You have to use immediately or within 6 hours. That is the rule. So then, and spectrometry was done on these combinations like propofol ketamine or propofol or ketamine dexamethasone, and there was no crackling, no separation. Spectrometrically, there was no difference between the color combination also. And this propofol ketamine was started in 30 years back when there was a war with the Iran, Iraq and America. And at that time, one of the anesthetists from America, Barry Fradberg, who started an opioid-free anesthesia practice, and he has invented Ketofol. And he has given 900 patient anesthesia with only Ketofol without anything in the ship on the sea. Wounded patients, then they have gone for amputations, they have gone for the suturings and everything. So at that time, TIVA started very frequently. And in 1996, there was a change of TIVA. And since last 5 years, TCI TIVA. But still, I will tell you, in America, it has not FDA approved TCI TIVA. European countries have approved the TCI TIVA, but no American anesthetist is using TCI machine in their practice. But in India, according to my survey, personal survey, hardly 0.2% of the anesthetists all over India are using TCI TIVA machine. And that is why myself, Dr. Siv, and everybody is promoting TCI TIVA in all over India with the workshops and seminars and with this type of the lectures. And we are very fortunate that now people have started a TCI TIVA offices in India, like Acromed, Elevate, then Bad Captain. They have offices in Delhi, Chennai. And these machines are average 2 lakhs rupees per machines, these Elevate machines. And if you go to PKPD or LRS, they also come in this range also. So it is, I think we can take that machine TCI TIVA and start your practice. Start with TCI TIVA, then TCI TIVA. And this monitor is also available in 2 lakhs rupees, around 2.5 Covidian in India, very small one. So people are asking me, sir, these are the machines very costly, so we will never use this TCI TIVA. But at that time, I say that in your practice, the patient is safe, then you start TCI TIVA with this monitor. Hardly it takes. You ask your HOD, you ask your other people. Even in India, they have started giving in the installments also, like vaporizer. They mount the vaporizer, you use the inhalation agent, the cost of the vaporizer will be free. Like that, they will start this with dish machines also, TCI TIVA. So my message is very simple, Edward, through your platform, to all the anesthetists, those who are hearing. Start TCI TIVA in your practice. It's a very beautiful for the anesthesia practitioner. And when we have used, we are love this technique of anesthesia. And I'm not against the inhalation anesthesia. But at least you should consider this part of the.
So you are saying it is going to be the future.
Yeah, it is going to be future. You see, my question is that in space, trolley is not there. At that time, in this Voyager, see, if you go to the references in Google, then 3 anesthesia given in space location. At that time, TIVA was the only answer. So that is the beauty of TIVA. So that's why I'm telling you that.
Are you using muscle relaxer along with TIVA?
Yeah, muscle relaxation is one of the part of that. But whenever you are using muscle relaxation, I will say use BIS monitor. BIS monitor is the compulsory when you are using TCI TIVA. And if you are using, but some people say that we are not well versed with this BCI machine also. But now in America, when you are doing TIVA practice, BIS is compulsory now. So in India also, within 2-3 years, when you are using TIVA practice, then BIS will be compulsory. So BIS will be, I'm using in my practice compulsory. And since last 10 years, I'm using and comfortable. Not all patients, for short surgery, I'm not using, but for all laparoscopic surgery, all ENT major surgeries or head and neck surgeries, and I'm very comfortable with using. I put my patients around 45 to 50 of BIS and I'm comfortable.
So what is that partial intravenous anesthesia? Is that any term called PIVA?
Partial intravenous anesthesia is partial intravenous anesthesia means partial. Means you use inhalation agent also in that part. But the inhalation agent is in a very low concentration. That also I am using some laparoscopic anesthesia sometimes when they put a trocar and they insufflate the carbon dioxide. At them there is a sudden hypertension. At that time, I have to start a low dose of the sevoflurane, like that is called a partial intravenous anesthesia. That is not a TCI TIVA then or TIVA practice. So partial PIVA, that is called PIVA. Partial intravenous anesthesia is given by all these TIVA drugs and with low concentration, where you can give sevoflurane or isoflurane, those you are using, or desflurane. So low concentration of these inhalation agents are used in TIVA practice.
Sir, we are often use the term that monitored anesthesia care and conscious sedation.
Monitored anesthesia care. See, this plastic surgery unit, I always give monitored anesthesia care. Suppose some patients are going for some removal of the wards or some liposuctions or something. So I give local anesthesia with some of the sedation. The main principle of monitored anesthesia care is safe sedation, relieve the anxiety, and good analgesia. That is not monitored anesthesia care. Here the monitor is compulsory, and you have ample of drug using like benzodiazepine, propofol, ketamine, narcotics you can use in monitored anesthesia care.
Okay, sir. In the presentation you have mentioned, oh my God, what is the relation between oxygen and magnesium?
Actually, in our anesthesia practice, we learn from our residency that oxygen is for the patient when we are giving anesthesia. When I started giving magnesium sulfate, at that time, before magnesium era and after magnesium era, I'll tell in my practice that when I was not giving magnesium sulfate in my anesthesia practice. At that time, I have to give more dose. My patients are waking sometimes with vomiting, sometimes with crude way, sometimes with not irritated way. And when I started giving magnesium sulfate, everything was settled down. Means one dose of magnesium sulfate, it gives almost every effect at each level. And believe me, when those who have used this magnesium sulfate, they will experience that how. So it is called an intravenous oxygen. Whenever you want to give oxygen intravenously, then you can. So I called, and this word is there in the internet also, oh my G, with oxygen with magnesium sulfate. So, oh my G, oh my God, that's all.
Okay, sir. Thank you very much. Already they have started requesting your PPT presentation and books also. You have mentioned that.
My presentation I will share with you. My all infographics I will share with you. And I have created one textbook for the students where drug infographics for the drug infographics especially for the TCI TIVA and TIVA. That is a 46 page of the color book. And it is a soft copy. I will also give my all these Epsilon textbooks of around 1,000 pages to you, and you can distribute to your all.
I will share to me.
Yeah, definitely, sir.
Thank you so much, Tushar, for spending your valuable time, and also I thank the Shivakumar sir. We come to the end of this session. I thank the organizer, the sponsors, the Akrula, the A1 Logics, and also the Anaesthesia TV. Thank you, one and all the viewers. We will meet next week with more interesting topics. Thank you, Tushar. Thank you, Shivakumar sir. Thank you.